Okay, so I have with me here today Dr. Martyn Pitman, who will be familiar to many of you as I've interviewed him twice previously. Dr. Pitman's obstetrician and gynecologist, decades of experience, worked and educated in Winchester. And if you want to know more about him and if you want to see previous material that was recorded, please find the interviews that I've recorded on my channel. Um, in a previous video, we discussed child A and child B, and the obstetric picture that is available from the documents that we can dig up at this point in time in relation to those twins. In today's interview, we're going to discuss triplets that were born at the Countess of Chester over this 2015 to 2016 period, with a particular focus on child O, but we're also going to discuss child P. So with that being said, hello to Martyn.
Hi, Chris, and thanks for inviting me back. It's been very interesting going through these cases in a similar way to the way I looked at baby Zane B. So I hope today's session will be informative and helpful.
Absolutely, I'm looking forward to hearing more about it. But before we do that, we're going to discuss the event in Manchester briefly. So I met you for the first time in Manchester. Obviously, we'd spoken previously, and we met many other people, and there were many, I think, powerful talks, including your own. And I must say, Martyn spoke brilliantly, and that was a really enlightening talk for me because I already knew his story. We've already discussed his story on this channel, but there was one bit I know a lot of people have seen it now because it's on the 19 Nurses channel. I've had it on my channel. There's the part where you had the notice board with all the thank you cards that really brought.
It was my lounge floor. It was my lounge floor actually.
Oh, okay. It looked like a notice board. That really brought. I knew you'd had a lot of support, and I knew you'd had some prominent people supporting you and so forth. But yeah, that really brought it home to me how unfair it was. And yeah, it was just one of many powerful moments. But I just wanted to ask, your reflections on the event and how you felt about it.
I thought it was an immensely powerful and worthwhile meeting, really, and it was it was an honour really to be asked to go, let alone to present my story really. And as the final part of my talk, I tried to link in what I believed all the way along were significant links between what happened to me and what happened to Lucy Letby, and I believe we were both whistleblowers. And I thought the meeting was incredibly powerful. I thought it was pretty terrifying. I thought it was a very strong meeting in the sheer breadth of the individuals present and presenting was incredibly powerful. To selected people from healthcare settings, legal settings, friends and associates of Lucy Letby was and also similar ongoing cases that are deeply concerning. I'm thinking about Channel Islands and Will Powell, who I thought was what an incredibly emotional presentation that was.
Yeah, absolutely.
So yeah, I thought it was a really impressive meeting, and it certainly opened, I think, a lot of people's eyes to both the what I think most of us believe are highly deficient aspects of Lucy's investigation and the legality behind her case, and the difficulties that the face now is trying to unpick it all. So so huge credit to 19 Nurses and yourself for staging that, and I thought it was a very, very impressive and positive event really. So yeah, well done. And it's good that that the presentations were recorded so that the word can get out, because it would have been a shame if what was presented was restricted purely to the audience that were in attendance. So yeah, so I thought it was very impressive.
Yeah, I agree. One thing I will say is I hope the University of Manchester fix their heating in the future because it's pretty
Wasn't it
cold.
freezing in there? And it certainly it was designed to keep you awake, wasn't it?
Yeah,
So
yeah, well, there's
it
no,
certainly certainly succeeded. Yeah,
yeah.
it was bitter. Maybe they're cost cutting, or maybe the solar panels aren't working, or something.
I think it just didn't work, did it? I think like, she kept saying, "I've asked about the heating. I've asked about the heating." It never seemed to come on, unfortunately. But yeah, yeah, it was very powerful. I mean, I think for me, also I know a lot about Lucy's case. Um, some of the kind of highlights for me were the other cases that I didn't know as much about. You mentioned Will Powell, and there's some interesting stuff on Guernsey situation that I don't want to say too much about because there's a lot of legal issues. But yeah, it was very powerful, and I was honoured to be there as well. And I felt a lot of optimism after it because I think Mark, you know, provided a clear pathway for Lucy to be exonerated, which we hope is going to happen sooner rather than later. So
Yeah, from a sort of a personal perspective, it was very positive of me to see Jim Thornton there as well. So I think being one of the, if not the first obstetrician who went on record to say that, I was deeply concerned that it appeared to me that so minimal, if any, focus had been levelled at the obstetric and maternity side of the cases. To have somebody of Jim's standing, reputation, and experience saying exactly the same, and to then hear from him that there is a panel of obstetricians now that have been appointed by Lucy's new defence team to look at the cases. It is incredibly powerful because I genuinely believe that. I mean, I don't think anybody could argue that what they're going to uncover once the maternity notes are released is going to be new evidence that wasn't initially presented, and I think that will completely blow the babies are all well and stable nonsense out of the water. I think it's going to torpedo Dowie Evans' script that these babies are all well and low risk and doing well. Some of which I think will come up in what we're going to go on to discuss today. So, yeah, it was great. It was I drove back down south after thinking, wow, that was so worth the trip. It was really good, really good.
yeah, it's interesting to think about the obstetric aspect of this from a court and legal perspective. Because certainly when I began this journey of learning about Lucy's case, if I'd have been in the jury as an example, I wouldn't have thought, oh, well, I haven't heard any obstetric information about these infants. There's just absolutely no chance. What hope has the jury or indeed the judge got of understanding the importance of maternity and obstetric information? I would say they have no chance.
No, no, and
That's why,
it shows a fundamental failure in the way these cases are investigated, Chris. And I think we have to face it. The NCA tried their best, and there's a document that I haven't looked at today, but I've seen it recently where they recommended, in the very early stages of looking at the investigation of the cases from the Countess of Chester, they recommended that it should be a panel of experts, and they actually listed who they recommended, and in there, in stark black and white was, consultant obstetrician. I don't think it said fetal medicine, but consultant obstetrician along with statistician and geneticist. Why didn't that happen? Well, because the principal inverted commas expert decided that no, that wasn't necessary. He would do it all. So, but again, that should surely have been an alarm bell and a red flag that you've got a long retired paediatrician, not neonatologist, who believes that he has sufficient cross specialty expertise to do the work of all of those other specialties. And I know people have come back after saying, "Oh yes, but in the court there was a radiologist and an endocrinologist."
let me be clear.
That's different.
Let me be clear on this. When Lucy Letby was first arrested, it was entirely on the basis of Dr. Evans. Like
Absolutely.
we know that for a fact.
Absolutely.
Yeah. And basically, Paul Hughes had already decided. He says in the Liz Hull, Caroline Cheatham interview, I basically already decided Lucy was guilty. So
Mm.
the radiographer is just there to say, oh yeah, there was some air, which they Professor Owen Arthurs was never in support of the prosecution case. What he actually provided doesn't support the prosecution case at all. Um, these other experts, like the two of them, say nothing. They're not even in the court case at all. That's Devaros and Kenny. Sally Kinsey's role is extremely limited. It's just to
And questionable, as we found out
and
last time
and
about twin
questionable.
A.
Yeah. You know, Hindmarsh obviously has done the insulin. That's another matter. That's nothing to do with Dr. Evans, but we believe those conclusions to be again highly questionable, certainly hypothetical, and flawed, frankly. And this Marnerides is a couple. He's in the court case for a couple of days, and he's been criticised by other pathologists. And then there's Bohin who did the peer review, the so-called peer review, where they just handed the conclusions and he said, "Oh yeah, I agree with everything that you've done." So there's not a lot, but the key thing really is
But
to
even something which I'm sure you're aware of, Chris, but I've only recently stumbled upon was how Marnerides reached his conclusions, because I didn't realize until very recently that when he was questioned in the court case, he admitted that he hadn't looked through,
yeah,
he hadn't done a de novo review of all the clinical records.
yeah,
He based his pathological findings on Dowie Evans's reports.
yeah.
So that, and if that isn't a confirmation bias, then
Well,
I don't know what it is really. So
it's,
he didn't have an independent look through the clinical records. So this is what we've got. These are the initial post-mortem findings. No. No, he looked at Evans's report and then based his findings on that. So it's hardly surprising what he came up with. I was going to focus a bit on that in relation to
yeah.
what we're going to discuss today. But it's just, how on earth did that get through?
Well, I suspected for a long time when I was hearing about this police investigation and the way it had been run and so forth. I suspected for a long time that what had happened was, Dr. Evans had basically convinced them to let him run the whole thing. And I suspected that was the case for a long time. Now we know it's the case. We know that's what happened. The police obviously did an absolutely lousy job, and they've just allowed Dr. Evans to take over the whole thing. And he's prompted all the experts, and he said, "Oh, we don't really need a panel. I'll just send these few things off. Oh yeah, they've said I'm right." We literally know that's what happened.
Mm.
Um,
It was just rubber stamping, wasn't it? It was
yeah,
just,
yeah. I mean, I have described in my book the peer review as rubber stamping,
mm,
but I think that largely applies to the others. The only one you
yeah.
could say it doesn't apply to is Hindmarsh, who's now deregistered and not even a doctor anymore. It's actually you could have. I mean, I've written a chapter on the defense experts, but that could have been a lot longer. Gone into well, I've gone into as many of the problems as I could, but yeah, they're all either deregistered or they've got problems, or they're retired, or they're not qualified for what they do in the first place, or they're asked to comment on things they don't know anything about, like Sally Kinsey, or they didn't turn up for the court case, or they're barely in the court case. It's just it boggles the mind, actually. When you consider the consequences for the defendant, it should be the
Yeah,
highest standard.
it is staggering. And as I said, like the meeting in Manchester, it's terrifying.
Yeah,
Having not on a completely different level, having crossed swords with the UK legal system in the employment tribunal, it kind of makes sense to me how this sort of thing can happen.
yeah. I
Um,
mean, you'd have a great insight into it, of course. I'm just learning. I'm learning more every day, but I'm just learning about. I mean, I obviously didn't come into it with completely wet behind the ears, but um, I did. I did 2.5 years ago. I would have thought if you want to put someone away for murder, you need to do a good job of it. There needs to be very strong evidence in the court case, and it needs to be of the highest caliber. I think. I mean, I've said previously in regard to some aspects of the court case, you wouldn't put this in a GCSE project. If you'd be laughed out of a GCSE project if you put this in as a 14, 15-year-old, and that's in a court case to decide whether or not someone goes to prison for the rest of their lives. So I think that's, frankly, it's just, I mean, again, I've used this phrase lots of times. It's a national embarrassment.
mm,
Um, the standard should be much, much higher. We're the first nation, I think, to say, oh, we're the best at this, we're the best in the world, we've done this, our legal system's been in place for so long, blah, blah, blah. Are those claims real? Do they really have any
I think
credibility?
we've rested on, as a nation, we've rested on our laurels on that really, and just assumed that it's correct. And I think it's also been bred by the legal system, particularly the judiciary, getting themselves into a position where they are immune to challenge,
Yeah, yeah, I
which I
agree.
think is highly relevant to what's happened here and why it's so fiendishly difficult. As your last interview um, with Michael O'Brien showed, I mean, it's just to try and unpick. In his case, a murder charge that he was wrongly convicted for, to try and unpick that and get it turned around is incredibly difficult. But primarily because the judiciary are so intransigent and unwilling to accept that maybe errors on their part could be made.
Yeah,
Staggering and terrifying.
yeah, I
Yeah.
agree. I agree entirely. So I'm going to share my screen at this point, and we're going to primarily discuss today child O and child P, so which you can hopefully see on the screen now from the expert panel report. This is the summary, conviction, opinion, and conclusion. So I think most of our discussion today is going to be on child O. Child O has been a major part of the post-trial discussion. We are going to discuss child P as well, and just want to mention that the information here is that child P died from pneumothorax, which means a collapsed lung that was suboptimally managed. So we're going to discuss that in some depth, but we're going to discuss child O in great depth, I believe.
Yeah.
So
The
child
first thing to
O,
point the first thing to point out here, Chris, nomenclature wise. Now, I'm acutely aware that most of the viewers watching this are going to be non-medical, non-obstetric, non-pediatricians. So I'm going to obviously my slant is mainly obstetrics, but I'm going to venture off into some of the neonatal bits that I think I'm able to give an opinion and judgment on. But the first bit is just a highlight here is the nomenclature here is a little bit complicated and is incorrect because the normally with multiple pregnancies the first baby that is delivered is termed either twin one or triplet one, and these have been changed. So because basically baby O was the second baby delivered, not the first one, and baby P was the first one. So they're kind of the wrong way around, but it's important to highlight that at this stage.
yes, that's a good point. And as far as I know, the reason that was changed around was because the prosecution wanted to do it that way, and they were just allowed to do it that way.
Yeah,
They were pretty much just allowed to do whatever they wanted, seemingly. Um, but yes, that's a good point, important point.
but again, it shows the and if this had been done optimally, properly, I would argue, with obstetric input from day one. If this had got to court, which I doubt it would have done, then that would have been changed. It would have been, can we keep the nomenclature correct? So in other words, the first baby that's delivered would have been the other way around. But
Yes.
it's kind of academic, but it's kind of important in a way, really. But it does show that if something that fundamental can be complicated, it's a bit
Mm.
bizarre, really.
And that was true for child A and child B as well, wasn't it? If I remember rightly.
I think it may well have been actually.
Yeah.
Yeah, yeah,
Yeah.
yeah.
So
So
so go on.
sorry, shall I start?
Well, just all I was going to say was child O is the quite infamous case where there's a very clear subcapsular hematoma that's ruptured, and there is evidence of needle damage in this aspiration process. And we both saw, I mean, Martyn mentioned in the introduction Jim Thornton's presentation in which he provided some of the evidence why it was a traumatic birth of the infant. Um, so those are the kind of the factors that feed into these infants and that have been recognized by the panel. So I just wanted to remind people of those things in case they don't know. So yeah, we'll continue from here.
Okay.
Martyn will speak on these infants. If I need to query anything, I will.
Yeah, do chip
Um,
in, Chris, if there's anything that
yeah,
I overlook or miss out. So what I'm going to do, I'm going to use a similar sort of strategy and technique to the one that I used. I read through the comments that have been registered the last time we did the clinical discussion about the twins A and B, and the way I did that seemed to be well received. So I'm going to do a similar thing this time. Some of this is pretty complex, say for the non-medical, non-obstetric, non-neonatal viewers. I will try and simplify this into and not use too complex medical terminology.
I'm most likely to interrupt to ask you to clarify something.
Okay. So I think before we get into the nitty-gritty of the actual case, I think that there are some very, very salient points about this case that I think are worthy of highlighting. And I think for those viewers that aren't that clued up with the Lucy Letby investigation and particular conviction, the case of Baby O was the very first case that the prosecution's expert was given to look at. So this is the case where Dowie Evans drove up from his home in Carmarthenshire to Chester police station, and apparently he very proudly stated that over a cup of coffee and a 10-minute look through these notes, he was absolutely certain that Baby O, Triplet O, was killed through malfeasance, and it was deliberately inflicted harm that tragically led to this baby's demise, rather than natural causes, which was the conclusion from the post-mortem. So this is a sentinel case, and I hope what I'm going to explain, or be able to explain over the next hour or so that we've got, is how there are elements of this case that I think absolutely epitomise the deficiencies in how the investigation that allowed one questionable expert to be able to superimpose his theories on this case, and also I think torpedoes the whole prosecution case against Lucy Letby. So I'm hoping that I'm going to be able to demonstrate how I've come to that view. Need to be completely open and honest. And this is just to pacify the trolls who no doubt are going to be all over this. I haven't had access to the medical records. I still don't think anybody's had access to the maternity obstetric note. Having said that, there is plentiful information available in the public domain that would allow any card-carrying medic, let alone experienced consultant obstetrician and neonatologist, to be able to make, I think, very valid criticisms about how these cases were managed. So that's where I'm coming to it from. I haven't had access to anything that isn't readily available in the public domain.
Yes,
so
I think we should just emphasise before we begin that we know that this wasn't in the court case. We know that they haven't had access to these notes, and we know that it should be. I mean, it really just simply should be. So just to emphasise that once more.
Yeah, absolutely. And I think from my bread and butter throughout my career was complex, medically complicated obstetric pregnancies, high risk obstetrics, and fetal medicine. So in my 20 years as a consultant, I tended to look after the vast majority of the complex multiple pregnancies that went through our unit and triplets. So I think I'm in a pretty strong position to discuss how they should have been optimally managed. So I'm going to do a little bit of background for the non-medical viewers about multiple pregnancies. So the first thing to say is that in any obstetric unit, and I don't really care whether it's a relatively small district general hospital delivering 2,500, 3,000 babies, similar to the unit that I was in, or a big teaching hospital like Southampton or Liverpool, when triplets are passing through, it's a big deal. A higher order multiple pregnancy is an even bigger deal, and that's basically because they're pretty rare. Now, to quantify that, and we don't know a lot of the details about this pregnancy. For instance, I haven't seen anything that confirms whether these were spontaneously conceived triplets or whether they were through IVF. I don't think that's been declared. The incidence of naturally occurring triplets is about 1 in 10,000. So in a unit of our size at Winchester, which I think was a little bit smaller than Chester, you would expect to see a set of triplets every one in every 3 years or so. So that's why it's a big deal, because they're rare events. If you're working in a unit where there's a lot of IVF, then they tend to be more common. But there's still not something that you're going to see every day of the week or every year of the calendar. Now, it's a bit more complicated than this, but the other thing I'm a little bit unclear about is the actual what's called chorionicity of this pregnancy. There's a lot that's been put in the paperwork that's available that these were identical triplets. Now, if they were, so identical triplets basically means that they come about through one egg being fertilized and then it cleaves into 3. That's incredibly rare. That's about 1 in a million pregnancies. That's incredibly rare. What's more likely, and it may be this, and there's bits that you can glean from the information that's available that makes me think that wasn't the case, that these are actually what are called fraternal triplets rather than truly identical triplets. And in that situation, you end up with 2 eggs being fertilized, and then one of those cleaves. So you end up with, and that's what I think is probably more likely, and this I can't prove it, but it's more likely. So you end up with a situation where you have 2 twins that share a placenta, so they're monochorionic, and then you have another, if you like, singleton pregnancy. So you have 3 babies, 2 of them came from one egg and 1 of them came from the other, and that's far more likely. The issue with that is that what we can tell is that this was a high risk pregnancy. Yeah, any multiple pregnancy with triplets, any multiple pregnancy, even if it's twins, where you have monochorionicity, so in other words, the babies are sharing a placenta, that ups the risk status of that pregnancy, and a monochorionic triplet pregnancy is just right about the top of the tree as far as of obstetric risk is concerned. So part of the conclusion I've drawn in that regard about these probably not being the 1 in a million chances is there were comments from early on when the mother had a scan. She was told really from quite early on that one of the babies was likely to be smaller. Now, to me, that would suggest that they were preparing her for the possibility of what's called twin-to-twin transfusion syndrome. So again, quite complicated, but it basically, to simplify things, in the twins that are sharing the placenta, it's basically they have 2 babies, but they have a single plumbing system, if you like. So there is a possibility that the combined blood volume of the 2 twins, more can go to one twin and less can go to the other. So you tend to get a bigger twin and a smaller twin, and that's a very high risk situation in a twin pregnancy, but even more so in a triplet pregnancy. So a mum being told that there's a possibility one of the twins, or a probability or a likelihood of one of the twins being smaller, that would suggest to me that they were concerned about the possibility of twin-to-twin transfusion syndrome. So other things that you could glean from the early communications is that the mum was told that she was unlikely to be delivered at the Countess of Chester and unlikely to have postnatal care there because of cot availability, and that makes perfect sense. It's a big deal. It's a big deal for the obstetricians because they're very intensive pregnancies to monitor. They're going to be up in the antenatal clinic loads. They're probably going to be admitted because poor mums carrying triplet pregnancies are huge. So they get very uncomfortable, very likely to go into preterm labour, and very likely, if not inevitable, to be delivered at preterm gestation. So there's going to be lots of ultrasound scans because it's impossible to judge how each of the 3 babies is growing just by using clinical examination and tape measures. You're entirely beholden on fetal medicine and ultrasound and blood flow investigations to check how the babies are doing and to guide you as to when delivery is going to be necessary. So if we look at the antenatal planning of what should have happened with this pregnancy, when you're planning the management of any pregnancy obstetrically, you look at what you can predict and what you can't predict. And the secret of being a half decent obstetrician is preparing for the unexpected. And if you do that, more often than not, that doesn't happen, and you end up pleasantly surprised, and you plan for the worst, and you then get the best. And you end up with a healthy mum, and in this situation, 3 healthy babies. But if you don't do that, and if you cut corners, and if you don't plan, if you don't notify all of your allied colleagues, and this I'm talking about anaesthetists and particularly the neonatologists, it can go very, very badly wrong. So as soon as this lady had her 12-week scan, somebody, and you're looking at basically the consultant obstetrician who's responsible for her care, looking at his diary, thinking, well, Mrs. Smith is 12 weeks now, she's carrying a triplet pregnancy. And then you can make certain guarantees, and particularly with triplets, I would have said to this lady, look, we need to be aiming, assuming everything goes well with your pregnancy, to get you to 34 weeks. That is as far as you are realistically going to get. It's almost exceptional to be able to get a triplet pregnancy beyond 34 weeks. And that's if everything goes well. So you can obviously get a bit like the poor mum with the twins A and B, far more likely to get hypertensive blood pressure problems in a multiple pregnancy, particularly if this was this lady's first pregnancy. So you'd be mindful of pregnancy-induced hypertension, or more concerningly, preeclampsia. So you should then be looking in your diary to think, well, at or around 34 weeks, I need to warn the neonatologist that they're like, if you're going to plan to deliver them at the Countess of Chester, you need to forewarn the neonatologist, look, at around this time, we need to try and have 3 cots available, because that's huge in a small unit to have 3 cots available. It's also huge for staffing, because there's ample evidence backed up by the Royal College investigation into Chester that there were ongoing significant problems with staffing availability and seniority of staffing. So to suddenly put 3 premature, potentially complicated triplets on your neonatal unit is a monstrous thing to consider. So they need to be warned, and they need to be warned well in advance. And also, as far as the planning, to have appropriate seniority of staff available for the delivery as well, because I think it'd be pretty unusual for units to consider delivering triplet pregnancies without a consultant obstetrician being present, unless you've got a really experienced resident doctor, what we used to call a senior registrar. And you never quite know, particularly with the sharing of the placenta issue, how well the babies are going to be. So you need to make provisions to have, I would have thought, at least the consultant neonatologist present and enough nurses to be able to manage 3 babies. Now, I'm not convinced, from what I can see, that level of planning happened in these cases. But that's, again, it would be far easier with appropriate access to the notes to be sure about that. The other thing is that you've got plenty of opportunities with these pregnancies, because you see them so frequently. Imagine this lady was up at the hospital at least every couple of weeks, and you've got recurrent opportunities as the consultant or the senior registrar who's involved with them to reappraise the situation, see how you're going, and then to give more advice and guidance to the neonatologist and the anaesthetist about when you think the delivery is going to happen. Did that happen in this situation? I don't know. So moving on a bit. So again, I'm going to talk now about predictable things, because of what I said before about it being inevitable these triplets are going to be delivered early. You need to be thinking about, are there any steps that you can institute in this mum's management that are going to decrease the risk to the babies, increase the chances of having a smooth arrival into the world and being able to make that incredible transition from a water breathing environment inside their mum's uterus into our air breathing environment. And the thing I'm talking about there is the use of antenatal steroid injections. So again, for the non-medical people out there, steroid injections was one of the most amazing advances in obstetric and neonatal care of our generation, really. And it was basically found out that if you expose a pregnant mother to pretty high doses of antenatal corticosteroid, you could cause the little cells in the baby's lungs that make the surfactant, which is a slimy fluid that coats the alveoli, the little air pockets in the baby's lungs, and it basically aids them in being able to breathe air. So if you give the mum steroids, and they're normally given 12 hours apart by intramuscular injection, they go across the placenta and they give the baby's alveolar cells a boost to produce more surfactant. So what do we know about what happened in this case? Well, the evidence that we have that you can access shows that the mum was given steroids at 23 weeks. Now, I'm not clear why, whether that was just done just in case or whether it was done because it was concerned. But their use at 23 weeks is contentious because the pneumocytes in the lungs that produce surfactant don't really have the ability to do that before 24 weeks, from my understanding. So the use of steroids at 23 weeks is contentious and probably was of little benefit. The other thing that you need to bear in mind is for optimum use of steroids, for why they use, you want to be basically exposing the baby to them around about 24 hours prior to their arrival in the world. So, and our streamlining of steroid use, even compared with when I first started in the specialty, was amended appropriately due to concerns about the potential risks of babies being exposed to serial doses of steroids, because it was shown to affect growth and also was shown to be disadvantageous for their brain development. So whereas in years gone by we used to give serial doses to mothers, we stopped doing that because of that concern. So what we know about this case is this mum was given a second round of steroids at 30 weeks gestation. Now, again, I'm not sure why, whether that was elective, whether it was just in case, or whether it was because it was concern then that something was going on, that she may go on to labour. But she didn't, because she got through to a more advanced gestation, so several weeks. So the issue there is that the efficacy of the steroids drops off from the time they were given. So if there were 1, 2, 3, in this case, number of weeks since exposure to the steroid, their efficacy would drop off. So it appears from what we can gather that the decision to deliver this lady was made on that. There's two different things that I could see. One of them that she was in early labour, and the other one, which is far from surprising, was that she was uncomfortable. Now, they may be related. The first one is significant. The second one is inevitable. But if, to a certain extent, whichever of those was the decision or prompted the decision to deliver, I think it's highly questionable that a decision wasn't made at a high level obstetrically from a consultant to say, I think there is significant merit in us getting more steroids on board. So delaying the delivery for 12 hours, 24 hours to get the steroids on board. And that's particularly important when then we see what happened to particularly babies O and baby P. And both of them, I would argue, went on to develop signs of respiratory distress, which are typical in preterm deliveries, and even more so in multiple pregnancies. I don't know if there's any definitive proof of that, but certainly from clinical experience, you tended to find as an obstetrician that a 34-week twin or triplet would behave maybe like a 32-week baby compared with a single baby of the same gestation. So you're even more mindful of them getting more significant respiratory distress. Again, that's anecdotal from clinical practice rather than, I think, being evidence-based. I think there are issues about exposure to the mum to steroids. So about planning the delivery, as I said, a little bit uncertain about the nature of the decision to deliver. I suspect the mum, as all multiple pregnancies are, twiddle triplets, once you get through to this sort of 30+ week gestation, the poor mums get incredibly uncomfortable. Covered already about whether the neonatal unit was genuinely ready, equipped, staffed, and had appropriate consultant cover for when the decision was made. In a similar way, if you like, to what appeared to be a distinct lack of preparation with the neonatologist for the arrival of twins A and B. I get the distinct impression with these, which, let's face it, would have been potentially far more of an issue workload-wise and cot availability-wise. But again, more will be gleaned from looking at how many babies are on the unit at that time and getting pertinently useful information from the notes. I'm unconvinced about the seniority of the personnel present in the delivery. The report from the dad when he was questioned, I think it was in Thirlwall, was that the individual undertaking the cesarean section, so the principal obstetrician, in his words, was female and looked very young. So I don't know. I've not seen any names. I don't know. I don't know whether that was a consultant. One would hope it was a consultant, but I don't know. As I said earlier on, I would be amazed. Particularly, this was a delivery in working hours during the working week. It would be really unusual in my experience for a consultant not to be involved with the actual delivery for two reasons. One, because the actual complexity of the mechanics of the delivery can be a challenge because you've got three babies. Equally, so that's from the baby perspective. From the maternal perspective, the thing you worry about is bleeding risk because the womb is massively expanded because of the presence of three babies and 2/3 placentas. There is a far higher risk with these pregnancies of getting major bleeding. So sometimes it can be sort of all hands to the pump to optimize the mum's safety and to reduce blood loss. So it's a bit late when somebody's lost half of their blood volume to suddenly call a consultant obstetrician who's in an antenatal clinic. And the same from the neonatal perspective. I don't know who was in theatre. I don't know whether a consultant was present. I don't know. So it's pointless trying to make judgment on that.
Yeah, just I think something to emphasize at this point. It's just that these are triplets. This was something that it doesn't really form part of the court case at all. They barely even, it was barely even mentioned that this is complex. It's not, it's not just another birth.
Yeah. And it's even more complex than that, Chris, because we know these were monochorionic twin pregnancies, and there was a big emphasis, which I still struggle with a bit from the obstetric perspective, about all the talk is about the speed, the haste of the delivery. And that can only be because of the chorionicity thing, this thing about switching blood supplies. From the neonatal perspective, it's a huge issue, though, because you just don't know how these babies are going to be. And it's such an incredible physiological transition for even a completely well, uncomplicated single baby to make the transition from an amniotic fluid breathing environment in utero to an air breathing. It's astonishing, really, that any of us get here intact. But that takes a good few steps up the risk pathway with a multiple pregnancy, particularly monochorionic triplets. So you need to have all of your best team there, seniority, and the hope. Again, going back to what I said right at the start, prepare for the worst, and then you generally end up being pleasantly surprised. I'm not convinced from what I could see that was the case. So moving on to the actual, what we can glean about the delivery. Well, that's essentially shrouded, as far as I can tell, in complete mystery. As I said before, there's a huge focus, and I think that's been brought about by Xu Li's panel's claim about inflicted birth trauma from the speed of the delivery. That's the only place I think that has come from, apart from the story that the parents gave, which I think in a way it is in itself quite concerning, because it's reported that the delivery of the interval between the delivery babies was a minute. Now I don't know whether that's between the first and second ones or whether they were all delivered within a minute. That seems to be unclear. Now I never, except in the crash emergency situation where you kind of look at the clock as soon as the patient's anaesthetized, and you literally look at the seconds going by before you get the baby out. And if push came to shove as a senior obstetrician, you should, and I'm not saying this in any boastful manner at all, but I think when I was at the peak of my operating prowess, I could, from knife to skin to getting a baby delivered, I could do it within 10 seconds. But that, you develop a technique that enables you to do it incredibly quickly, but you wouldn't do that in a routine cesarean section. So I never in a routine cesarean section, twins, triplets, and I delivered loads and quite a few triplets in my time. I never remember going into one thinking, right, stop clock. Primarily because if you put yourself under that degree of time pressure, you lose a degree of the safety of what you're doing. So it's kind of less haste, more speed, or more haste, less speed, whichever way you want to look at it. But putting yourself under that degree of time pressure, unless it's absolutely required for life-saving reasons, is I don't think clinically beneficial. Now, from the parental recollection, you've got some pretty startling things that they said. You know, I think it was the dad said that at one point there was blood shooting over the drapes and splattering against the wall behind them. I mean, that's just astounding.
Yeah.
And apparently all went over the mother's face as well. So I struggle with that. I struggle to compute what was going on in that cesarean section to cause that degree of blood.
How unusual would that be?
Oh, incredible! I never had that in, as far as I'm aware. I can never remember. I mean, obviously, theatre sizes vary, but they're normally, for a theatre to be big enough to have triplets, it's got to be pretty sizable. So the fact that the blood got from the operating table and splattered on the wall, that is exceptional. I can see maybe how blood maybe splattered and go over the drape onto the parent, maybe, but that's only, you know, by definition, less than a body's length away. But to go, you know, 6 foot, 12 foot across an operating theatre, I don't think I ever experienced or witnessed anything like that in my entire career. So very, very rare. So I think, you know, I've written on the notes I've made here that you need the notes. I mean, all the stuff about, was it a rapid delivery? Who did the delivery? Why was the level of the blood loss, the ferocity of the blood loss? All of that should be so easy to glean from looking at the notes and speaking to the people present. It really shouldn't be difficult. From the obstetric perspective, I think all that was discussed in the trial was that it was a routine cesarean section. So you infer from that it wasn't rushed, it wasn't complicated. The delivery of the babies wasn't technically challenging, which will be relevant in a minute when we come on to talk about the theory about delivery trauma. And you assume that there wasn't a problem with postpartum blood loss. So that would kind of justify the, you know, uncomplicated aspect of the cesarean delivery. So from what we can glean, there didn't appear to be any apparent very early neonatal concerns. So the triplets were delivered, they'd have had their own little, they'd have probably had their own nurse. I would have thought at least a couple of neonatal doctors in theatre, one with hyper consultant. And it appears that everything was straightforward. And I just wonder if that was the case. So they would have had blood tests done, they'd have had lines put in, they needed to go, or the two were going to concentrate on, needed to go on to CPAP, which is not at all unusual in this situation, probably worsened by the likely respiratory distress cause from I would argue, or made more likely from the non-recent exposure to steroids. But I do wonder if that lulled the neonatologist into a full sense of security about the babies. Possibly, I don't know. So then we move on to, actually, because, you know, we had it with the twins A and B, and we had it with all of the other babies, and it's certainly relevant to these three. Now, Evans's claim that these babies were all doing well, they were stable, there were no concerns about them. Well, was that the case with these babies? What can we glean from what is available to the public now? Well, I would argue that there wasn't any evidence that particularly baby O was clinically stable. And if you look at what was recorded in the notes and the observation chart, baby O had a persistently raised heart rate, had a persistently raised respiratory rate, had a degree of temperature instability, and there were also concerns expressed about delayed meconium passage, which, bearing in mind there were concerns about the abdomen being distended, you know, could have been significant. I think he didn't pass meconium until 36 hours.
So just to mention briefly, this is not the only infant. There's a central aspect of child C as well.
Oh yeah, absolutely. So it appears that as a consequence of some of those, even though Dowie Evans has completely trivialized them, it appears that on the basis of those, baby O was given antibiotics. That's the only reason that I could find. And then a little bit later, when the initial destabilization, as Dowie Evans put it, was coincident with the baby vomiting, and then they did some blood tests and found that there were some concerning markers in the baby's blood. And again, for the non-medical people, the baby's lactate was increased, which is a non-specific marker that the baby's not doing brilliantly. The bilirubin was increased. The bilirubin is a hormone that's produced by the liver, so that had gone up, and the baby was becoming acidotic. So basically, the amount of acid in the baby's blood was increasing, which is a reflection either that the baby's not breathing well or is developing what's called a metabolic acidosis, which is sort of a chemically mediated acidosis, none of which is indicative of a baby that's in peak top form, despite what Dowie Evans led us to believe. So we then come on to the crux of both of these babies, really, but more so baby O than baby P, and that's the finding of a neonatal hepatic subcapsular hematoma. So this is, I think, probably the finding of most clinical relevance in this poor baby. Now, it was interesting to hear Jim Thornton's slant on this in Manchester, because this is something that I never saw in my entire 30-year career in obstetrics. I knew it happened, and when you're taught as a junior obstetrician, and particularly doing manipulative deliveries, more so with vaginal delivery of breeches, but equally with manipulative deliveries of multiple pregnancies, particularly because they tend to be preterm. You're always taught to try and restrict the amount of rotational shearing force that you put on the baby's abdomen. And the reason for that is because the possibility of that causing abdominal injury, and particularly injury to the liver. Now, again, for the non-medical people, the liver is a pretty critical organ for all of us, equally, if not more so, in preterm babies. And they're disproportionately enlarged in preterm babies, and they're covered by, it's like a thick cling film. And that's why subcapsular hematomas are initially so difficult to diagnose.
Can I ask you a question about the liver?
Yeah.
So I've read, I don't know if this is true, so you can immediately say this is true. Like, people often see the heart as fundamental, but the heart has one basic function, whereas the liver has numerous functions. Is that correct?
Yeah, it is. It's a critically important organ, Chris. And it's also got an incredibly rich blood supply because of the way the vasculature goes, and particularly in utero and in the neonatal period. It's an incredibly important organ that's got a massive blood supply to it. So you don't want to traumatize it. And this membrane, the capsule around the liver, acts, if you get a little bleed, it tamponades it. It's a bit like if you get a dead leg, a bruise. The membrane over the liver would stop that from developing, and it might actually stop it, because I think the theory is with subcapsular hematomas, they're probably more common than we get to see because they just self-limit. They clot off. Right. The baby picks up the blood count, and you're none the wiser. But I'd never seen it in my career, and it's interesting that Jim Thornton, he's more experienced and time-wise, and has worked in busy units than me. He'd never seen it in his career either. So clinically, from the obstetric perspective, these are very, very rare events. They're probably more common in the neonatal side. And I saw an interview, I think it's one of the early documentaries on Lucy Letby, where a female pathologist was interviewed, and she said in that they were relatively common in neonatal post-mortems. And one would assume that's because multifactorial, but these babies are more commonly preterm, and more commonly complicated, and more commonly have had active resuscitation. So I think all of those are more likely. So what are the causes of subcapsular hematoma? This is critical, I think, in what we're dealing with here. So running through them, they can be caused by prematurity, they can be caused by low birth weight. Obviously, those two can be related. They can be caused by birth trauma, particularly shearing forces, rotational procedures of the baby. They can be caused by hypoxia. They can be caused by misplacement of the vascular lines that neonatologists put in, particularly UVCs. Coagulopathies, so blood clotting problems in babies, can cause it. Sepsis can cause it, so infection. Maternal history of hypertension and preeclampsia can cause it. And interestingly, they're more common, from my reading, in multiple pregnancies, and particularly in monochorionic pregnancies, and that's probably because of this shift of the blood volume. So if you just go through those, we certainly had prematurity, we had low birth weight, although the babies weren't actually a bad size. There's a possibility we had birth trauma, although I don't think there's any objective proof for that. Undoubtedly, there was hypoxia. There's a possibility the baby was certainly treated for infection, and we've got an element to pregnancy. So we've got enough background risks for this pretty unusual condition, which is critical because Dowie Evans ignored all this and said that, oh no, the actual mode of death was destabilization with gas, with air down the nasogastric tube, and then an air embolism. So he's ignored all of this and gone for another pathology, which is quite astonishing, really. So, and I think it was clouded a bit. We touched on it earlier on about Marnerides' post-mortem findings. It's very emotive what he described, wasn't it? So he's been given Dowie Evans's theories, and he's based his PM findings on that. And he gave this very emotive report that the injury to baby O's liver was equivalent to what he'd seen in a car crash. Now, just put yourself in the position of a juror, a non-medical juror, and you're being told by an experienced pathologist that the level of liver damage to this baby was equivalent to what he'd seen in a car crash. And he also went on to say he was pointedly questioned, was this something that could be attributed to resuscitation measures? So, and he said, in his experience, no. But of course, he doesn't know the standard and efficacy of resuscitation at the Countess of Chester. And what we know is that there are significant concerns about a lot of the procedures that were done on that neonatal unit. Yeah. And it's not beyond the bounds of possibility that the resuscitation methods used on babies was also deficient. So how he can make that decision is particularly pertinent to what was going on in the Countess of Chester neonatal unit, I think is somewhat questionable.
Yeah, I'll just add as well that two other pathologists have looked at this. Obviously, they haven't looked at the notes, but then he said, I didn't look at the notes in the court. So, and the two other pathologists have looked at this and said, he can't make such definitive statements. No. I think he's simply wrong.
Yeah, absolutely.
And I think there's a third pathologist as well that said that. But I think they've gone a bit quiet, so I think they may be.
Yeah. So of course, if you think back to then how this was all declared to the world, we had a press conference, the first press conference, when Richard Taylor basically recounted the report written by Svilina Dimitrova and Neil Ayton, and his theory was that the hematoma was punctured by what we're going to come on to in a minute, an intravenous cannula that was used to perform paracentesis with view to deflating the baby O's abdomen.
Just remind us what paracentesis is.
Yeah, I'll come on to that in a minute, actually. That's the next thing I'm going to be talking about, Chris. And then, of course, it was complicated further by when Xu Li did his subsequent press conference in February. The conclusion that he drew was different from that, in that he claimed that the rupture of the subcapsular hematoma was caused by delivery trauma. Now, of course, so the anti-Letby trolls had jumped on this to say, oh, the experts can't even agree. Now, I challenge that, and I would say the concern here is that from the prosecution's perspective, you have a so-called expert who is absolutely dogmatically 100% certain that his view in all of these cases, but particularly this case, had to be due to inflicted harm, that somehow Letby managed to punch or traumatize this baby's liver, or these babies' livers, to cause these hematomas and their subsequent rupture, and that there was no other explanation. Now, and I think in your interview with Steve Watts, he said something in that in his experience, any expert that is that unilaterally 100% certain, that should have raised massive warning signs, massive red flags, and the fact that it didn't is hugely concerning. From my perspective, from her new defence team's perspective, I don't think it matters. I think it's a very positive thing that you've got different experts that have come up with different conclusions. I don't think it matters. This baby died, I think, unquestionably from an acute rupture of an hepatic subcapsular hematoma. How that rupture happened, I don't think is relevant, and nobody's ever going to be able to prove it. So whether the capsule was burst by the needle, or whether it burst spontaneously, made worse by active resuscitation, I don't think it actually matters. I think it's a very positive thing that you've got different defence experts that have come up with different theories. I don't see that as a weakness of the defence's case at all. It should have been seen as a massive weakness of the prosecution's case that their expert didn't come up with or even accept that there were alternative modes of death for this baby when they were staring him in the face. So okay, so yeah, you mentioned earlier on about the cannula placement. I know this in my view, this is the elephant in the room. So for, again, the non-medical present, this poor baby was in extremis. The baby destabilized. It had then he then arrested and was undergoing significant resuscitative measures, including use of adrenaline, which is used to stimulate the baby's heart. I think eventually he was given dopamine, which is something to again aid the baby's circulation. Throughout all of this would have been given cardiopulmonary resuscitation. So the externally the baby's heart would have been compressed. Interesting that there are huge concerns about how all this happened and who was involved, though, because when there was significant concern about baby O's destabilization, only the baby was moved into the sort of the ITU area, and a single peripheral intravenous access point was established. Now, anybody who's ever worked in a neonatal unit, if you've got a baby that you're concerned about, you have to go for central access. So a UVC or some other central line, or you put in two peripheral lines. You don't leave them with one little peripheral cannula that are the most vulnerable to being dislodged. But that's what happened here. Not only that, but after that cannula was sighted, the registrar who did it then disappeared. It was called off clinically elsewhere. And astonishingly, there was no consultant present on the unit. And again, I reiterate, this was during normal working hours. So when this baby decompensated and eventually arrested, not only did the registrar have to be called back, but it took 39 minutes for a consultant to arrive. Now that's just completely unacceptable in any neonatal unit during normal working hours, and that would be a long time if they come in from home. But for it to take 39 minutes for a consultant to get there is inexplicable and unacceptable, I would say. So when this baby was, it sounds like when this baby was in extremis, because of the degree of abdominal distension, a decision was made by one of the consultants, and I'm not going to mention any names for obvious reasons. One of the consultants decided to undertake what's called a paracentesis, to try and, the theory being, I believe, to deflate the abdomen. So the theory being that the baby's stomach, which had been noticed earlier on, even the day before, that the baby's stomach was distended. The theory was that if you deflated some of that pressure, it could aid the ability to resuscitate the baby, and particularly to ventilate the baby. Now, this was augmented by the fact, and this is true. Again, I'm not a neonatologist, I'm stepping out of my comfort zone, but there were significant concerns about the ventilatory settings that were set up for both of these babies. So tubes are put down into the baby's tracheas, so an endotracheal tube, and then they were keyed up to the high-tech ventilatory equipment, and the pressures that were exerted on the baby's breathings were excessively high. Now that's relevant in both of the babies for different reasons. In baby O, if you inflate the baby's lungs at too high a pressure, you decrease the amount of blood that is able to get back to the heart. So you decrease the cardiac, what's called the cardiac output. So that's the amount of blood that the heart is able to pump around the rest of the body. And that's a significant negative physiological development for a baby. And it actually makes it harder for the baby to maintain the normal chemistry in the blood. So you're more likely to then develop too much acid in the blood and to become acidotic. And that was relevant for both of these babies. The other complication from it physiologically, and anybody who works in a neonatal unit will be aware of this, particularly in preterm babies, is if you increase the pressure above the baby's diaphragm, so where the lungs are, one of the unwanted side effects on that is you push the liver further down in the baby's abdomen. So you have to be aware of that, and particularly if you're then going to go on and consider sticking sharp objects into the baby's tummy. So that decision was made, and inexplicably, again, not a neonatologist, but I know enough about neonatal physiology to know that if you're going to stick anything sharp in a neonate's tummy, the one place you do not put it is in the no-go zone, which is on the right side of the baby's abdomen. And the reason for that is that you're worried about the liver. And the bits in the notes that report where this cannula was put denote McBurney's point, which is, if you were to go into casualty tonight with bellyache, Chris, and they were trying to work out if you've got an appendicitis, they press at somewhere called McBurney's point, which is it's an eponymous name given by a surgeon from hundreds of years ago. And that's basically near or where your appendix sits, and it's sort of low down on the right-hand side of your tummy. But it's irrelevant in neonates. It's just not used as a terminology in neonates. But anyways, cannula is put in the right side of the baby's tummy, and there are reports that it wasn't greeted with a whoosh of gas coming out of the baby's tummy. It was greeted with aspiration of frank blood, which should have been a huge warning sign.
It seems like a fairly obvious warning sign.
Yeah, because it basically means either what you thought was gas in the baby's tummy actually wasn't. It's a collection of blood, or you skewered it into something where you don't want to go, as in the liver. So I don't understand that. The other thing to throw into the melting pot in this is that the individual, the consultant that did this, is clearly a trained sonographer, because the same individual scanned the baby's heart to rule out there being congenital heart disease. Now, the technicalities of doing that and looking at you're looking at a moving organ. I used to do it as part of my job, looking at a moving organ with complex connections. The technicalities of being able to do that are infinitesimally higher than being able to use the same bit of ultrasound kit, which was clearly available in the unit, to guide your insertion of a sharp object into that baby's tummy. And you would use the ultrasound, and it would be dead easy to tell that below the baby's skin, where you're about to stick your sharp object, is either gas, blood, or an organ. It would have been dead easy to tell. Why that consultant didn't use the ultrasound machine, which by definition was clearly there to guide his insertion of that sharp object, a cannula, is anybody's guess. I don't understand that at all as a sonographer. So what else do we know? Well, the other thing that we know, which I think that hasn't been covered at all as far as I can see, to clarify things, is what we do know is that 2 blood samples were taken during this resuscitation. One was taken at about 13:30, when the baby owes hemoglobin, so the amount of oxygen carrying capacity in the baby's blood was registered at 197. And then a second sample, which is the thorny issue, at 5:30 was taken when that hemoglobin had dropped, but hadn't just dropped; it had spectacularly dropped down to 86. So it had more than halved, which by anybody's standards is a catastrophic, is evidence of catastrophic, life-threatening blood loss. And that was documented by the consultant who undertook the paracentesis procedure in the notes. So what we have to question here is with this baby, think about the whole clinical picture. This baby's heart rate was persistently elevated, the concerns with breathing, concerns with developing acidosis. I suspect what was going on is that gradually this hematoma was developing, and then the crash of this baby was due to the hematoma bursting, forming what's called a hemoperitoneum. So you lose the tamponading, the pressure effect of the membrane around the liver. You get acute blood loss into the baby's tummy. And the only way you're going to rectify that is to give blood. Now, I don't understand how any experienced clinician, consultant can can take a blood test from a neonate, see a hemoglobin of 86, compare that with the one only a few hours earlier, which was twice that level, and not then ask for a blood transfusion, because that's the only thing apart from surgery that's going to put this right. But that wasn't done for whatever reason. So that's my theory. And I think, if you think about what was going on at the time with the active resuscitation, so you're going to have somebody in between all of this pumping up and down on the baby's chest, are we really thinking that wouldn't be enough physical trauma to that poor baby's liver to cause what was found on the post-mortem? The other issue here, of course, and it is documented, is that even Dr. Bowen commented at one point that, in her view, when she looked at this case, she advised that further emphasis should be placed on the insertion of the cannula into this baby's abdomen. So even she was questioning how this was conducted, which I think is very pertinent.
It's telling, isn't it? I mean, I was really surprised when I saw that.
Yeah. Yeah, but I don't think it clearly didn't go anywhere. It clearly didn't go anywhere.
Let's not speculate on why.
No, absolutely. And of course, the other thing which concerns me about this is, and again, I saw this on one of the forums, that there appears to be a missing document around the resuscitation time. Like it's been named as a document number, and on that document apparently denotes exactly when the abdominal drain was put in and exactly when these blood test differences were recorded. Now it's interesting because apparently Mike Hall reports never seeing that document. Now one has to question if full and frank disclosure of the documents around these cases was undertaken, why the defence weren't given access to that critically important document, given the other issues about this case. And I think it plays to understanding that. So a lot of information. There's a few other concerns. We discussed the ventilatory mismanagement. So if you inflate the lungs with too much pressure, you decrease the venous return that gets back to the heart, and you push the liver down. We discussed the lack of intravenous access in an unstable baby. This actually got worse, because what you don't want in this situation is for an acutely shocked baby to then require you to urgently try and establish access, because that's incredibly difficult in these small babies. But what they did then was to insert what's called an intraosseous needle. This is a bit gory for the non-medical people, but if you can't get into a baby's vasculature, there are specific, what are called, and they're pretty brutal, because obviously you have to get through the baby's bone into the bone marrow. They're pretty brutal bits of kit. So you force this instrument into the baby's bone marrow, and you use that to give fluid. It was reported that they didn't have any of those on the neonatal unit, from my understanding. So they had to use what's called spinal needle, which is something that's used by anaesthetists. So again, you just wonder, well, what is going on in this neonatal unit? You don't even have the kit that you need in emergencies to do these procedures. So another red flag. Yeah. So we discussed availability of senior staff. The specialist registrar who was around, so the resident doctor who was around initially, was called away to look after another baby. It took 40 minutes for a consultant to arrive. My understanding is I think that this was from the parents, that the first consultant who came was a few minutes later seen in the car park having a cigarette. How? I mean, I don't compute how that can fit. And then we come on to the, what happened after this poor baby died. And this is, I think, Steph Davis, her findings are critical in all of this. So, what happened with the coronial notification of this death? I understand that the coronial notification was completed by the anonymized consultant, not by the consultant that had done the invasive procedure on the baby. And inexplicably, given what I've uncovered, there was no mention at all that the cannula insertion into this baby's abdomen, the drop in hemoglobin, was mentioned to the coroner. Well, why? It was fundamentally critical. There's evidence from the Thirlwall inquiry that the coroner had communications with with the department to say he couldn't find any evidence of mismanagement, but it appears that that judgment was made without being given all of the clinical information. And from what I can ascertain, which I think is what Steph Davis picked up, was that the coroner was only notified about the insertion of the paracentesis cannula some 3 months after the baby's tragic death. So that's a concern. And then we move on to a document I've only recently seen, which is I think we're gonna screen share this, which is so I need to do that from my side, Chris. Yeah?
Yes. Again, we've rehearsed this, but please just bear with us a second. So yeah, just move your mouse around, and you should get. There we go.
Okay.
Our rehearsal was successful.
Can you hear that, Chris?
Just bear with us 1 second. Yeah, we can see now.
So this is a document that was released from the Thirlwall inquiry. So this is basically what's called a hot debrief, which happened immediately after the resuscitation. So we'll just go through this fairly rapidly. The first thing to notice, given the concerns that we've been discussing over the last hour or so, is this bit here, which is the grading of what had happened. So there was an acceptance by the people that took part in this meeting that there was suboptimal care, but the conclusion was that different management would have made no difference to the outcome, which I think in itself is somewhat questionable. And then I think the other things that are divulged in this document are gravely concerning, because it seems to me that the team that were present that formulated this document used almost deflection tactics, and that there was a focus on, there was a query about why intravenous antibiotics were given. So the reason for that was respiratory distress, and there was a conclusion that it probably wouldn't have made any difference. There was an issue about TPN, which is establishing feeding for the baby. And there was a question about point 3, no record of the registrar examination. It goes on. So there's relatively trivial things were volunteered on this. But then it gets even more interesting. So a bit about the nursing notes. And then we move on to point 5, where it says all radiographs so these are x-rays, to be reviewed again. And this is fascinating, isn't it? In view of probable enlarged liver and importance of timings of films taken. So there appeared, bearing in mind that the consultant that presided over this meeting was the one who inserted the drain into the baby's abdomen, that there was already concern at this point about the baby's liver being enlarged and potentially pushed down. So, but that concern didn't extend to notifying the coroner about that or the placement of the cannula initially. Then point 6, concern about the delivery. Consult with the obstetric team and the possibility of a subcapsular hematoma being due to the actual delivery. So that may well be where Shoe leads. So was the concern for the neonates in theatre about the nature of the delivery of the babies? I don't know. And then in a way focusing then on aspects of good practice and good team working, 3 consultants present for most of the resuscitation. So that there's enough in that hot debrief of this case to make me question about what was going through the team's mind about what had actually happened with this baby. So again, can't answer that, but there's enough things in there to make me concerned that this was almost deflecting away from what could have happened.
Yeah,
I won't go into that anymore, but I thought that's quite a significant finding.
Yeah.
So just before we go on to a far briefer discussion about baby P, in view of what I did with the other twins and now this one, I've got huge concerns about the safety of procedures that were being done in that unit. You know, we've got evidence from from the previous twins about repeated failures of IV lines, particularly central lines, UVCs, and peripheral lines in babies, and delegation of that down, particularly with those babies with their prothrombotic tendency, that being delegated down to junior doctors, where you really want those to go in first time and get infusions running first time. We've got plentiful evidence of intubation problems, and that was very relevant to these babies as well. And I think the intubation of certainly baby O was undertaken by a pretty junior neonatologist. We'll move on in a few minutes to grave concerns about the recognition and treatment of pneumothoraces. And with all of that going on, one has to wonder about the standard of basic neonatal resuscitation that was present in that unit. If you're going to be deficient in basic procedures, then there has to be a question mark about the efficacy of the resuscitation. I think most pertinent to all of this is the parents' recording and reporting of what it was like in the neonatal unit when all of this was going on, and that's heartbreaking to listen to or to read. You know, they describe scenes of utter pandemonium, of chaos, you know, staff running around, of panic, and that's I can't compute how that can happen in the UK in the 21st century. And for parents to observe that and to be mindful of that when their babies are clearly suffering as a consequence of that is just beyond belief, really, in the NHS in the current era.
So I guess my comment or observation would be that we all heard in the press conference Dr. Hugh Lee say this hospital will be closed down if it was in Canada, basically. So now we've investigated and examined further the kind of background information that is available to us. So my observation would be that the more we look at it, the more that assertion looks valid. Would you agree with that?
Oh, absolutely. And I think you need to, again, going back to the Manchester meeting, it was very reassuring to me to hear Jim Thornton's, albeit limited, because he's as yet not really had any more access to the critical documents than I have, but both of us had exactly the same views, that there is more than enough in the documentation that's been released subsequent to the trial and from Thirlwall that allows any card-carrying obstetrician and neonatologist to be able to raise incredible levels of concern about what was going on. So I think Shuley's comment, that was one of the most, I'll never forget watching Shuley's press conference, and I thought that was an incredible response to a question. And I don't think any senior professional and any senior medical professional would say that they could legitimately question that. So, and I think it's interesting. We're doing this. I'm not sure when you're going to push this out, Chris, but just for the viewers, we're doing this recording the day after the Amos review, or the preliminary part of that was released, and I watched that yesterday when that came out with incredible sadness and shock, really, in that. And for those non-medical people, you probably saw it on the news last night, but the Amos review is an independent review conducted by Baroness Amos, who was commissioned by Wes Streeting, the Secretary of State for Health, to do a quick review of what's going on in UK maternity services. And she expressed shock at what she uncovered, which begs the question as to where she's been for the last 15 years, really. And it was sad for me because what she's found is exactly what I whistle blew about back in 2019. So to see it all being brought up as a shock, and that covers both maternity services and neonatal services. And I can't imagine if Shuley saw what had been going on at other units like Morecambe Bay and Shrewsbury and Telford and East Kent and most recently Nottingham, and now Leeds and Oxford and any other unit that you point your finger at, he would probably make similar comments, really, that in countries like Canada, a lot of these units wouldn't be supported to continue practicing. And it's desperately sad. And it's, I don't know how many more reviews, and if this develops into a full judicial investigation, how many more need to be done, because they all find the same thing. And what we need to do is to, as I was trying to do back in 2019 when I whistleblew, was to raise concerns and actually learn from mistakes and to amend what's going on. So yeah, I completely concur with Shuli's opinion, Chris.
Yeah.
So just maybe very quickly onto baby P. So this was the first of the triplets, and again, Dowie Evans claimed that this baby was initially destabilized, if not more than that, by injection of nasogastric air, and then changed later on to claim that this was another one that was given an air embolus. And astonishingly, it turns out that this baby actually had a significant pneumothorax, which is basically, again, for the non-medical people, it's where you get an air leak in the lungs, which then because of the way the lungs work, it causes, if you're lucky, a small part of the lung, but in this case, quite a significant part of the lung to collapse. So it moves away from the side wall of the thorax. So that's a medical emergency, because even in a fit, well individual, that's going to cause you to have problems with oxygenation. And the problem with this baby is that neither was it recognised nor was it adequately treated. And again, there were deficiencies noted, that the way that whenever a baby collapses and has respiratory problems, particularly neonate, one of the things you worry about is a pneumothorax. So there's clinical ways of detecting it. There's also something called a cold light, which is used to transilluminate, because these babies are so fragile. You shine this light and it shows the area of the collapsed lung, and that's something that's very, very easy to do, and it's clinically obvious. But for some reason, that wasn't available or wasn't used. So astonishingly, from the time this baby started to seriously destabilize, it was 3 hours until the pneumothorax was recognised and what they call needled. So in a way similar to what happened with the sort of one's brother, baby O, a needle was put through the chest wall to reinflate the lung. So you take the pressurized air out, and it enables the lung to re-expand. But then what you have to do after that is to put in a chest drain. So that's putting like a cannula in, so that it keeps the air out of the little pocket that's deflating the baby's lung, and enables it to adhere back again to where it was. And again, going back to the parents reporting about this, because they described the pandemonium and chaos that there was in the unit, but I think it was the dad said that he'd seen members of the medical staff actually Googling how to put in chest drains, which is just, imagine that. I mean, you've lost one of your triplets, and then a few hours down the line, you're then watching medical staff on a computer teaching themselves how to put it. How is that happening? So, huge concerns. And yet that was there was.
Is this is this like a relatively routine procedure?
Oh, absolutely. And again, there's been criticism about the inflation pressures used for the ventilation in baby O, which the theory was that with that one pushing the liver down and decreasing venous return. The same happened with this baby. The inflation pressures were equivalent, I think. So again, you'd have had the same thing. So you've got a baby that's destabilizing because it's lost part of its lung capacity. And then they ventilated the baby, put it on high pressures, which then reduces the cardiac return, reduces the cardiac output. You then get more metabolic acidosis and problems. So it then develops into this vicious spiral. And of course, the high pressures and the fact that these babies probably have respiratory distress due to the prematurity and the suboptimal administration of steroids mean they're more likely to get pneumothoraces. So you can see the whole picture of this developing. But this again was completely ignored by Shugley and the and in the court case, and you know, this clearly was a death due to air embolism. It's quite yes. Chest drains are pretty commonplace, Chris, in neonatal units. You know, most middle grades would be perfectly adept at putting in chest drains, and certainly most consultants would as well. And also with this baby as well, the other deficiency, which probably wasn't relevant to the death, was that the adrenaline doses that we used, I think, were twice the recommended level. So again, it just shows, you know, it's a drug error, and it shouldn't happen.
It's another indicator as well, isn't it, that these infants shouldn't have been born at this hospital?
Beyond, you know, these equally, these compared with the you know, the twins and so many of these other babies, that there's every evidence that the unit and the staff in that unit, through no fault of their own, were too stretched and unable to cope with the workload and the acuity and the nature of the cases that were coming their way. It's hugely concerning. I mean,
I think something that isn't always obvious or clear, and particularly to a jury, wouldn't have been made clear to the jury of laypersons, is like this, the specificity of dealing with these infants. That's something that I've learned, and it has become obvious to me, is that it's so specific, and it's not like, you know, when you're dealing with an adult. I'm speaking from a completely unqualified position here, but when you're dealing with an adult, sometimes there are specific conditions, but you know, obviously all their organs are developed, your body's developed, so it's not you. Obviously, there are life and death circumstances still, but it's not as specific. Whereas here,
no, absolutely. I mean, I qualified as a doctor. I did my house job, so you do a year of 6 months of surgery, 6 months of medicine, adult. I then did a casualty job, working in an A&E, so you become pretty self-sufficient. Again, dealing mainly with adults, but a bit of kids. And then I went into obs and gynae, and back then, it doesn't really hold now, but which is a shame, I think. But back then, you were encouraged, or if not, it was obligatory to do 6 months in neonates. And I did it quite early on in my obs and gynae SHO rotation. And I found it really difficult because I got pretty confident and proficient at adult physiology, and, you know, could manage adult emergencies. And all of a sudden, you're dealing with these little scraps, these little babies that break every single rule. You can forget everything you've learned at medical school, everything you've learned in your time in adult grown-up medicine, if you like, because these babies don't act that way. And it's even more complicated than that, in that there's a significant difference physiologically to how a 25-weeker premature baby responds to a 32-week, or even more so a term baby or a 42-week baby. So it's incredible. And, you know, I was confident then at getting lines into adults and putting central lines in and things like that. And then all of a sudden you've got these babies where you can't even do that. See, and even doing basic blood tests was difficult. So yeah, it's a unique specialty. And of course, the parents of these triplets experience that, because they managed to convince the crew from the recovery crew from Liverpool to take the surviving triplet to Liverpool. And then again, you know, so sad and traumatic to read, but they said it was like two different worlds. You know, what they experienced with the management of their surviving triplet at Liverpool was chalk and cheese to what they'd. And it was crazy stuff like, you know, what you think would be basic hand hygiene, that they said there didn't appear to be any importance or structure put on washing your hands at Countess, suggested where they were immaculate and impressive in what they did at Liverpool. And that's the most basic you know, infection control procedures. So yeah, neonatology is a unique specialty, and caring for these little babies is not something that anybody should take lightly. And you know, significant, very significant concerns with both of these tragic losses as there was when we discussed
Hmm.
the twins A and B.
Yeah. So do you have anything to add to what we've discussed? We summarized it very neatly there. I don't know if there is anything to add. Oh, let me. I've got something to add. So remember, I want everyone watching this to remember, Dr. Evans has said, basically, very little can go wrong with an infant. He gave a couple of examples. Basically, if they're breathing okay, if this, he very crudely simplifies what is a very complex and very specific topic, and you can see that's what he's done with his so-called diagnoses. I don't think they're diagnoses. I just think they're hypotheses. But it's just like, oh yeah, basically this has happened and that's happened. And you contrast that with the obviously what Martyn has provided today, and also what you see in the report, which is very specific, forensic, um, deeply qualified and an expert examination and analysis of numerous factors, which is just completely lacking in what Dr. Evans has done, in my estimation.
I think there are two sides to that aspect of Dowie Evans, though, Chris. One of them is, does he actually genuinely believe that? And I find that very hard to believe. I mean, the guy, there's challenges to him about his level of experience. He wasn't there's a lot of stuff online about, he wasn't a neonatologist. Well, that's, he clearly practiced some neonatology. He set up the neonatal unit in the hospital in Wales at a time when neonatology was in its infancy. So you can't really criticise him for the fact that he didn't do what is recognised now as specialist neonatology training. But the guy clearly has been a paediatrician for decades and was experienced, then moved into the medical legal part of his practice. So I find it inconceivable that somebody who's done decades of service in an acute paediatric specialty can genuinely believe that the neonates don't do things in an unpredictable fashion. And I only worked on a neonatal unit for 6 months, but I saw enough to make me realise that is complete rubbish. Otherwise, why would you need a neonatal intensive care unit? If they came out, screamed, and everything was completely predictable and they all did well, then you wouldn't need neonatal intensive care units. Yeah. So I don't genuinely believe that he believed that.
Okay.
I think he thought he was going to get away with it. And I don't think that guy had any perception at all that there was going to be the level of scrutiny after Lucy Letby's conviction that there's subsequently been. If you look at his past history with his checkered course of medical legal involvement, no cases have had anything like this level of scrutiny and challenge, and a lot of them were sort of pre-social media. But I think he's been found out. I think he said so much stuff in that courtroom that was beyond belief, really. And I think he thought he was going to get away with it. He had a unique style with the barristers, which was clearly gleaned from his years of experience of interacting with barristers, and he was very, very dismissive. And he got away with it, but he got away with it because he was never really appropriately challenged by another medical expert, which is there are so many travesties in this case. And I said all the way along, if any other neonatologist had walked into that police station or been appointed by the NCA to look at these cases, then we wouldn't be having this discussion now. And Lucy Letby would probably be happily married and sat at home with a couple of kids.
I think it's important to emphasize his performance in court wasn't good. It's just that it was kind of the equivalent of like me playing against Lionel Messi and me having, right, when you play, you've just got to kick the ball into an open goal. And then when Messi plays, he's got to dribble through like a world-class players. Oh look, I won. It was that kind of unbalanced contest, except that he didn't even have any opposition. So he didn't even have, it wasn't even delivering an open goal. It was almost the ball was already over the line before he even started. It's just but if you actually look at what cross-examination we've seen, he doesn't perform well at all.
No.
In fact, at times it's embarrassing.
a lot of the time it was embarrassing, but he got away with it because it wasn't opposed.
Yeah.
And all the theories about why the defendants didn't appoint experts, I and also I think it's allied to why Lucy was advised or encouraged, if you like, by Ben Myers to actually take the stand. I think it was. I think both of those are related. I genuinely don't think either of them thought they could lose, because she was so certain that she was innocent. So why wouldn't she want to defend herself? Because she'd never been in that position before. She didn't know what, as I know to my cost, what it's like being subjected to experienced barristerial cross-examination is a pretty awful experience for anybody, even if you're 100% innocent. But also, I suspect Ben Myers thought that Dowie Evans was going to be kicked out. I think he believed his evidence was going to be, which he should have been.
Which he should have, obviously.
And I think it all spectacularly backfired.
Yeah. Anna
So
was saying that. Anna Doherty was saying she just thinks Ben Meyer was overconfident.
yeah, yeah,
I mean,
yeah.
I can't really comment on that, but I
No,
respect Anna's view for sure. It would
I
explain.
can't imagine how it must feel. I know these barristers are pretty thick skinned, but from both sides. I can't imagine how Ben Myers must be feeling, but I also can't imagine, how I don't know. Was Nick Johnson completely taken in by Dowie Evans? Did he genuinely believe that he was a caliber expert and that Lucy Letby was the evidence was sufficient to convict her? I don't know.
It's very hard to say, isn't it? I mean, I find the whole world of barristers very strange because although we work in very different fields, the whole foundation of what we've both done is that our opinion and what we're saying is authentic and integrally correct. You can't always be correct, but you try to be correct whenever you can. Obviously, with a barrister, they have this very strange world in which they often have to argue very strongly for things that they either don't believe or know to be wrong.
Mm.
And I just can't imagine that.
No.
I don't know how I would do it.
No.
So we don't know. He could have believed it 100%, or he might not have believed a single word that he was saying. I don't know. I don't know.
You have to wonder with some of the techniques, that the things that he focused on, about the pajamas and the going commando stuff, and you just think, really, if you were that desperate to go down that route, are you? But knowing that the jurors sat there non-medical, they were potentially going to view that as, I don't know. You can't get into their heads, can you?
I mean, I would hope. I know for a fact, I can say this definitively. Other aspects of the jury, it's difficult to put yourself in their shoes. But I know for a fact, if I was sitting there, I'd be thinking, why on earth am I hearing about this? This has got nothing to do with the case. I just heard the testimony from Lucy. This is total. I know I'd be sitting there thinking this is total rubbish. I know I would. Whether the jury were or not.
But those jurors were 10 months, Chris. It must have been mind-numbing.
Oh, absolutely.
And it's no, and I think the whole way it was structured, to hear all of the prosecution stuff when they were pretty switched on in the early months, and then all the limited amount of stuff in Lucy's defence was all left to the end, wasn't it? Because of the way, or Judge Goss's reluctance to allow the defence side for each case to be heard after the prosecution side. So the whole thing was structured to basically, it's all primacy and recency, isn't it? And in the jurors' minds, that they were hit with the, if you like, the smoking gun cases, the insulin cases, and the ones that she's guilty. And then to add to that, the decision that if you decided that she's murdered one of them, then it doesn't matter. It doesn't matter about the others, really. If you think she's murdered them, it doesn't really matter about how she murdered them. That doesn't really come into it. It's astonishing. So reminiscent of the witch trials of old, isn't it? It's really terrifying.
Yeah, absolutely. So that's I think a good note to end on today. So thanks again for joining us. Thank you for sharing your expertise, and that'll be a really interesting episode for people to listen to. And we may do another one of these in the new year. I'll give some thought to what other infants we could look at, and we can go from there.
Cool. Okay, thanks, Chris, and happy Christmas to you and to all the viewers.
Yeah,
Thanks for what you're doing.
no worries. You too. Really appreciate it. Thank you.
Cheers.